I'd like to bring you back a little bit into the clinics, and the question is, why should we pay particular attention to a specific metastatic site like the bone? So, well, 1/3 of our patients will eventually develop skeletal metastasis from renal cell cancer, and as already shown today, the presence of bone metastasis has been associated with a poor outcome in renal cell cancer. Bone metastases were shown to be particularly destructive, and there are in fact higher rates of skeletal-related events in patients with renal cell cancer and bone metastasis than in patients who have bone metastasis from other tumors. And in particular, hypercalcemia appears to be a dramatic issue. This figure illustrates the survival of renal cell cancer patients with bone metastasis depending upon the type of first skeletal-related event. And what we can see here is that the curves are quite separated. And patients who develop as their first skeletal-related event hypercalcemia survive significantly shorter than those whose first skeletal-related event was surgery for bone pain. Despite the use of novel agents, bone metastases were shown to be associated with a poor outcome. So even now in the era of targeted agents, this is a PFS and overall survival analysis recently published, clearly showing a difference between PFS and overall survival in patients with or without bone metastasis. And interestingly, in this analysis, the presence of bone metastasis alone was shown to be an independent predictor of overall survival and of progression-free survival. I believe that these data clearly reflect an urgent need for an additional treatment for bone metastasis. So targeting the bone includes currently 3 strategies: drugs, surgery, and radiotherapy. Let me start with targeting the bone by drugs. So the development of anti-resorptive agents have really revolutionized the treatment of patients with bone metastasis and certainly have brought great improvement of quality of life. And here in particular, biphosphonates were shown to effectively inhibit osteoclast-mediated bone resorption. Is this irrelevant in patients with kidney cancer? It is relevant because subgroup analysis of large randomized trials in fact clearly showed that for the patients with metastatic renal cell cancer, these patients derive a significant benefit when compared to placebo. And the benefit derived from zoledronic acid was a reduction in the rate of skeletal-related events, an extension of the time to the first event, and a longer median time to progression of the bone lesion. However, the widespread use of biphosphonates in kidney cancer has been limited in the past by some adverse events, and in particular here the potential toxicity of renal impairment that may arise from the use of zoledronic acid was a concern. And in addition, there is data that the osteonecrosis of the jaw, ONJ, may be exacerbated in patients who are undergoing treatment with anti-angiogenic agents. This is also a reason why regular dental examination is required. And while novel agents like denosumab appear not to affect in the same amount the kidney function, they have the overall incidence regarding the development of osteonecrosis of the jaw is similar to zoledronic acid. So when we look at the data we have in the clinics and regarding efficacy and side effect, we have to say that the clear benefits of zoledronic acid much outweigh the safety concerns. What are the potential advantages of zoledronic acid beyond control of bone metastasis, beyond induction of apoptosis in osteoclast and tumor cells? Zoledronic acid was also shown to inhibit tumor cell motility, adhesion, and invasion, to inhibit the growth of endothelial cells and the adhesion of endothelial cells, to inhibit angiogenesis-relevant kinases, In animal studies, significant reduction of the primary tumors were observed, a significant reduction of vessel density, immune relevant functions, inhibition of visceral metastasis, reduction of tumor cells in the bone marrow has already been mentioned today, reduction of interleukin-6, which is a key, a major driver of progression in kidney cancer. And all of these direct and indirect anti-tumor activities make it clear why zoledronic acid was able to significantly improve the recurrence-free survival and disease-free survival in the adjuvant breast cancer setting. This is the case of a patient of mine, a lady who was diagnosed with renal cell cancer at the age of 71. She underwent nephrectomy. 3 years later, she was diagnosed with a bone metastasis and with soft tissue involvement. She was an intermediate risk patient. I referred her to the surgeon, however the surgeon said the resection is not feasible, so we included her first in a phase 2 trial on bevacizumab plus sorafenib, and in the same time we started treating her with zoledronic acid. We had to interrupt systemic treatment with sorafenib bevacizumab due to hand-foot syndrome. She received radiotherapy. Then we tried sunitinib, again here treatment interruption or discontinuation due to hand-foot syndrome. Temsirolimus next treatment, which at least provided a benefit for 17 months. We extended the treatment upon progression with temsirolimus and bevacizumab. And then she discontinued treatment due to a venous ulcer in September 2009, and then she only received zoledronic acid between September 2009 and her death in August 2011. I simply believe that this survival data from achieved with in this patient a survival of 52 months from the diagnosis of metastatic disease can also be attributed to the fact that this patient was treated with zoledronic acid. What about bone targeting? Here we have limited data available. A generous approach, however, to resection of metastasis appears reasonable in patients with good performance status. Why? Because bone metastases are less likely to respond to targeted agents, because bone metastases arising from renal cell cancer are more destructive, because resection may reduce the risk of impending fracture, and because in general resection of metastatic disease was shown to improve cancer-specific survival. So this is a retrospective analysis in 100 patients who were operatively treated for bone metastasis. And this analysis clearly showed that radical surgery can lead to durable long-term responses, in particular in younger patients without fracture and negative margins. We had a similar retrospective analysis carried out in our own department, where we could show that metastasectomy is an independent predictor of survival, and half of our patients underwent metastasectomy for bone metastasis. And finally, the role of metastasectomy in patients with various metastatic sites was also demonstrated in this recently published analysis, where it was clearly shown that with complete resection of metastasis, the 5-year cancer-specific survival rate is significantly increased. I'm less enthusiastic when it comes to radiotherapy. Bone metastases and you are aware of this, are less sensitive to radiotherapy. However, a palliative role is certainly here to reduce pain, to induce mineralization, and of course to treat nerve and spinal cord compression. There are few data on a potential synergism with zoledronic acid and radiotherapy and tyrosine kinase inhibitors. To summarize, bone metastases from renal cell cancer are particularly destructive and cause higher rates of skeletal-related events rather than bone metastases from other tumors. I strongly believe that a distinct attention to bone metastasis or to bone disease is required, since novel renal cell cancer agents may offer limited local benefits. Zoledronic acid was shown to reduce the rate of skeletal-related events and time to progression in renal cell cancer. The various attempts of zoledronic acid, anti-tumor effects of zoledronic acid, in particular the anti-angiogenic effects, I believe, merit deeper investigation in renal cell cancer, not only in the palliative setting, probably also in the adjuvant setting. And despite the lack of prospective data, I also strongly believe that surgery has its merits and has repeatedly shown benefits in terms of overall survival. Thank you very much.